I think it's clear what the benefit or the potential benefit for the patient is. What's in it for the physician, Dr. Mullol? What's in it for the physician? What are the advantages for the physician?
Well, for the physician, depends. I think you depending on the training of the physician, on the how this physician is used to the things. I think a lot of doctors can feel very comfortable doing this kind of surgery, and maybe others that are used to use anesthetics and to have everything controlled and so on is not so easy for them to change and to move back to the past when polypectomies were done under local anesthesia or septoplasties were done under local anesthesia. What I really think, and I don't know if that is the point of you, and we need that from physicians because we are always having these discussions about the concept of evidence, is to have more data, more studies, comparing these procedures, not only looking at the beneficial effect for the doctor and the patient in comfortability or inconvenience or in reducing waiting list, but also in the two main objectives that you raise when you have a surgery on front, that are efficacy and safety. And in the moment that you prove that efficacy and safety is the same using both procedures, well, this very similar, then you can choose the one that reduce times, that reduce time of the patient in the hospital, that reduce risk, or that reduce cost to the health system. But I think at this moment, at least looking at the literature about this topic, there is no much data really comparing both ways, and always it's very much based on opinions of doctors or their own experience from doctors.
Dr. Leunig, what do you see as potential benefits?
I mean, the question is how to measure the benefits. I mean, there's a patient-related benefit, there's a doctor, hospital-related benefit. Again, assessment of data outcome, very important. I think there's a lack. We have to look for databases where we can get the data and show for the evidence. But in a short way, as long as the patient is happy with the local anesthesia, you will have a happy doctor, as long as he's not creating more costs than benefit. So this would be my benefit. And reducing waiting time for the patient, having more comfort because, a nice setting, a nice short team and less invasive because we have more precision medicine, precision surgery, having tools incorporated, new devices in this setting. This all is benefit.
Dr. Hopkins, what do you see as benefits for the physician?
Well, actually, it's probably harder for the physician because you have to be much more mindful of the operating environment. The patient is awake, you're talking them through the procedure, and there is much less room for error, uncertainty, delay, and inevitably, I think that actually makes it more challenging for the surgeon to perform the procedure itself. But the benefit is the satisfaction of the patients, and that's what we're trying to achieve with this.
Dr. Carrie?
I think that's absolutely right. You have a patient who you do a procedure on, and if it is something like a polypectomy, you have a patient who comes in completely blocked and a patient who walks out absolutely delighted, and it's immediate. It's not after an anaesthetic waking up. So the patient is generally very pleased, and of course that is manifest in the surgeon as well. I think there is some evidence out there that actually it is efficacious. It's limited evidence, and of course we've always got to be slightly aware of publication bias. But there are observational studies showing that matched pairs, patient outcome measures at 3 months are as good in local anaesthetic as they are in general anaesthetic cases, and there is evidence from Luke Rubnick's group in Calgary that there is significant cost-benefit saving in terms of quality of life over a defined period. But there's not a lot of data out there, and I certainly wouldn't want to suggest that there is.
Mm-hmm. Cardoen, if we're talking about health economics, this is the way forward.
Well, if I can tap into that, indeed. On how to assess whether some process is then better than another process, it's not only about the organization, it's also on the outcome. We're talking about satisfaction, also some limited studies on how to assess quality given a certain process that underpins how the procedures are done. And that brings me to the concept of value-based healthcare, and I think this nicely fits in here. Especially, and we're talking about health economics as well a little bit now, especially as there is a payer, there is a budget pressure on how we organize healthcare, then one model to take a look at this is through the eyes of value-based healthcare. But then what is value? Because value, it's a fraction. It's the outcome, clinical outcome that you can reach, given a certain cost that you make. And that's the idea of Porter that I'm telling here. So there are two buttons we can play, and I hear many of the doctors saying, okay, we would like to have the same quality of medical outcome, and then if you can do it in a better way, it's good. And if you take outcome with less cost, it creates more value. That's how the fraction works. But actually, perhaps you can also even have a bit lower quality if you can drastically reduce the cost. That would also create value. So there are different ways in how we can get things organized, both in the costing side and in the outcome side. Now, from my perspective and my experience, I think we still have a lot of work to do at both angles, in the numerator but also in the denominator. Because we're at first, and also in the registration and, for instance, how IT informations are underpinning our health system today, perhaps we're not registering the right clinical outcomes to really assess the true benefits it might bring, and then we're entering that era of PROMs, patient-related outcome measures, but also other ones that perhaps are a bit more difficult to measure. But also to the costing side, I see that there is many doubt or even not knowing what the cost of a procedure or the procedure in an entire treatment process or treatment plan, how this cost looks like. Very often we know how we are financed, what we get, but not what the process is actually costing. And that's really a step forward we need to take in the future, is to better assess the cost of organizing the process of bringing surgeries, whether it is then in an inpatient, outpatient, clinic setting, but assessing those costs is very difficult because we're also lacking a lot of data over there.
I'd like to take one of the things that you said and throw that to the panel. A bit lower quality, but much lesser cost. Do we feel confident with that?
Oh.
Please.
Yes, it's for me as a doctor, the first is the efficacy and the safety of my patient. And of course, in these procedures, I do not use a special, very expensive equipment or something else that is very expensive. So the first answer, or the first answers that we have to give is, what is the efficacy? If we do our job precisely in both, in general or in local anesthesia, like in general anesthesia. And the second is the safety. And what I would like to emphasize, especially in my country, is to think what happens with the patient after leaving the hospital. If he is from a countryside and the health system is not well organized in the countryside, we have to think about, because if you go to the court, the first question that arises is, do you thought about the patient, what happens up after he's leaving the hospital? So safety, safety, safety for our patients, because it's not a malignant tumor. We remove not a malignant tumor. It's a procedure that improves the quality of life. Okay, it's like the tonsillectomy. You know, there was a big discussion years before about the tonsillectomies, the bleeding after tonsillectomy, how many days we have to hospitalize our patients. And more and more we reduced the days, the hospitalization, the duration of the hospitalization, but we have to think about the safety. If there is a strong bleeding, if there is a complication, we have to cover everything. We have to think about everything that can happen.
Dr. Hopkins.
I would feel very uncomfortable as a physician and acting as an advocate for my patient to accept reduced quality, even if it meant significantly lesser cost. So I completely understand the health economic argument about value, and the need to consider the needs of the whole population, but I'm acting as an advocate for the patient in front of me. And so I have to deliver what I think is the best quality of care. And if I can deliver the same quality at lesser cost, that's great, but I personally would struggle to compromise on the quality of care.
I think it goes back to what you were saying about quality. I mean, how do you measure quality? Is quality measured just in the nasal score, or is it measured in the patient experience, coming to hospital, taking time off work? It's a very complex...
I hear two valid, if I may, remarks here. First one is yours. It's not only on the cost inside that hospital or inside the clinic. You should have that total cost of ownership perspective. It's the full chain. A full chain that even starts with caretakers and family that is supporting up to the full recovery. And we see that in many studies and evolutions, perhaps not only in this medical discipline, but more and more things are moving outside of that hospital, moving into home care, moving into other ways of creating health value. So if we do something in one chain, one aspect of the chain, we should really check for repercussions on the other parts of the chain. So that total cost of ownership, I fully agree. And with quality, of course, from personal view, I also would like to have quality, but there are 6 dimensions to quality. So then my question is, how do we define quality? And that's also, in my experience with physicians, in my experience with treatment plans, it's also very difficult to say what is now quality. In the phrasing, we all understand something about that, but how would you exactly measure that? And on which dimensions? Because also service or well-feeling or comfort for the patient can also be seen as quality. So there are multiple dimensions, so how to do that? Not only the clinical outcome, and of course safety is a very important one in quality, but there is more in quality than that.
Can I add something? For me, one very important factor is the responsibility. I have learned to act as a responsible physician. This is very important. This will follow me my whole life. And the second quality is, for me, satisfaction of the patient. You know, there are different surgeons. We can do a different job in different patients. If our patients are satisfied, if our procedure was efficient enough, you know, and if he is happy, this is quality. We cannot measure, because quality is something individual. If you ask all the colleagues, what kind of food makes you happy, or what is for you quality of life, you will hear different answers.
Yeah, that's subjective preference. That is inherent to services and service settings. That is what is making it more difficult than manufacturing processes as such.